Okay, so this is going to be our 16th lecture. My idea for this talk is to review the typical appearance of pleural effusions on the upright and supine study. I want to discuss some etiologies for pleural effusions, talk about some problem-solving strategies, and then finish up with a brief discussion of a few other pleural-related processes. I'm going to have two main sections, or chapters, in this talk. The first one is going to be about pleural fluid, and then the second one is going to be more geared towards pleural thickening. The pleura can be thought of as a sac that surrounds the lung. You typically cannot see the pleura, except for occasionally a lung fissure. There is a small amount of fluid which is normally in the pleural space. It acts as a lubricant, lets the lung slide up and down as it expands, but that volume of fluid is not visible. The most common or classic appearance of a pleural effusion is a opaque meniscus right at the costophrenic angle. An important thing to remember is that you need about 200 or 300 cc's of pleural fluid to be able to make this appearance on the frontal view. Now the reason for that is that when you've got an upright position, the most dependent portion is going to be hiding behind the diaphragm there, like that. So as you have like a really small volume of fluid, you're not going to be able to see it on the frontal view. Now once you get a sufficient volume, which I said was 200 to 300 cc's, then you're going to start seeing that costophrenic sulcus blunted or effaced. So this is the upright view. Now let's talk about the supine view. So we'll turn this character on his side, bring this thing down here. When we become supine, you're going to see this phenomenon occur called redistribution, which basically means gravity is going to get a hold of this pleural fluid and layer it out. When that occurs, you're going to get the development of a curtain-like appearance on the frontal view, like a real pale gray curtain. Depending on how much fluid you've got, it can be totally white or it can be really, really subtle pale gray. So as a quick refresher here, that's upright and that's going to be supine. And like I said, the denser the white appearance on the supine, the more volume of fluid that you probably have. Let's have a look at a real life case here. This is actually a normal appearance of the costophrenic sulcuses. Notice how sharp they are. Now let's have a comparison here on the lateral. Notice that we've got blunting bilaterally, not just of one but both costophrenic angles on the lateral view. They have that meniscus appearance. So this is the situation here where we've got a volume that's probably less than 200 or 300 cc's. The frontal view looks totally normal. We only see the pleural effusion on the lateral. So your most sensitive view for picking up a small pleural effusion is going to be your lateral view. And I'll show you here what a normal costophrenic sulcus is going to look like. It's got that downward sharp dip to it, so that is normal. All right, and again, comparing side to side, normal here in the red versus abnormal, blunted in the orange. Do another practical case here. So here's the same patient I just showed before, that blunted costophrenic angle there on the left. And for whatever reason, we repeat the study just a few minutes later, and now we've got a very different look. Zoom in on this. So what changed? Now we've got this veil-like or curtain-like opacity. It's kind of a pale gray, right? There you go. That's what changed. That's supine. So this is a typical appearance of a supine pleural effusion. I also want to point out how difficult it would be to compare this. So if you were wondering, or if somebody was asking you, hey, is it worse? It's really apples and oranges, right? It would be really, you would have to be practicing a really long time to accurately be able to say what volume on a frontal radiograph would stack up with the volume on a supine. Like I said, unless it was super duper dense, and then you would say, well, it's probably gotten more. So using this idea, we can get a rough guess about how much volume of fluid is going to be there depending on the way that it looks on the frontal view. So this would be about 200 or 300 cc's. Any less than that, we wouldn't be able to see it. When it gets sort of medium sized like this, you can get a liter or two there. And to totally opacify the hemithorax, you need about 5 to 6 liters of fluid. So it goes to show you how much fluid you can stick in that pleural space. 5 liters of fluid is a lot of fluid. Another practical case. Now the point of this is I want to compare and contrast a totally whited out lung from a big, massive pleural effusion. In this case, this was actually a large hemothorax in a setting of a trauma, versus this case here, which is total atelectasis of a lung secondary to a mucus plug. I showed this case in a prior lecture, but just as a refresher, because this is an excellent compare and contrast, notice the deviation of the trachea towards the whited out lung. This is a volume loss process versus sort of shifting of the mediastinum away from the whited out lung. This is a space occupying process. So that could be a big pleural effusion, or could be a gigantic pneumonia that's involved the entire lung or whatever, but it's a space occupying process that's pushing things over, as opposed to the atelectasis, which is by definition volume loss. So let's quickly review a few of the typical appearances. Like I said, this is the most classic. This is called by some people a posterior mediastinal effusion. It's that blunted sulcus there on the side. And then we've got this one. You may remember this from one of the earlier lectures. This can be quite tricky, I think. Compare this head to head with a normal. I want to point out where the top, or the peak of the diaphragm is on the normal. Notice that right there, how it's sort of in the middle, as opposed to this case over here where it's shifted more laterally. This is a subpulmonic effusion. And the trick to distinguishing this from the normal study is the shift of that peak of the diaphragm. If it's on the left, there's another clue that you can have. If you see your normal stomach bubble here, the relationship between that stomach bubble and the top part of the diaphragm, they should be pretty close together. If you've got widening of that, especially if you've got a comparison to look for, you may suspect that there's a subpulmonic effusion on that side. The third thing to compare here is one of these. This is a diaphragmatic eventration, which is, some people think it's congenital. most people will describe it as a incomplete development of the muscles of the diaphragm. They're usually on the right. It's a segment of the diaphragm that doesn't contract normally, and as a result it has this upward contour. It's pretty common. You'll see them all the time. You'll begin to ignore them. Just note that the peak of the diaphragm still is in the center there. It's not pushed off to the side, so that's helpful in distinguishing it from a subpulmonic effusion. So comparing these three characters, normal, the subpulmonic effusion, and the eventration, look for the peak of that diaphragm. It should be pretty well centered in the middle. If it's pushed off laterally, then you can suspect that you've got a little bit of fluid there. Now, those appearances are actually review from a prior talk. I want to introduce a new appearance here, which is this, the Encysted effusion. Look a little bit like that. This is fluid which is collected between the two layers of pleura along a fissure. It can have a rounded appearance and mimic a cancer or mass. What's actually causing this, we'll get a lateral view here, and I'll draw the fissures in, is the fluid sort of right there. And if you get a lateral view and you're lucky, arms out of the way, you'll be able to see that, sure enough, there's that fluid. And this is often seen in conjunction with sort of the standard look of a pleural effusion on that side. Short interval follow-up, it'll go away if you're confused, or you could get a CT if you really needed to. But in the setting of an effusion, get something that looks like that, centered right there, that's what it is. Take a look at a real case of this. So, sure enough, there it is. It's got sort of that lentiform appearance, and you'll notice sort of the gray opacity there below it where this is seen in the setting of an effusion. Some people will actually call this a pseudotumor. Alright, I want to switch gears slightly and talk about a different kind of process. The effusions we were mentioning before are sort of simple effusions. What if it's shaped like this? Notice that this effusion has got a round or an oval shape, almost like it's a mass that's protruding in against the lung. When you see something like this, you should consider the possibility of an empyema. Doesn't mean that this is an empyema, but it should make you think, could this be more complex fluid? Because a normal, simple, like water, won't stick like that if the patient is upright. How might you prove that? Like if you weren't sure? I want to introduce a new way to take an X-ray here, a new positioning technique, and I'll show you how you could prove it, the simplest way to do it. As a refresher, remember a standard PA radiograph, you've got the patient up, the PA, the nomenclature is the direction of the X-ray beam, right, posterior to anterior, so something like that. Now, what we've got here is a patient that's laying down, and they're not laying on their back, they're laying on their side. So we could take an X-ray also like this, and this is called a lateral decubitus. And in this situation, we would have a right lateral decubitus. It's the right side because the patient's laying on the right. That's the standard nomenclature. So if we put our patient that has this bulge there, this bulging type of effusion, and we laid them down, we would expect that it would stick like that if it was complicated, as opposed to a simple pleural effusion, which will layer out. So the layering out is the simple one there in the blue, and the complicated one, or the loculated effusion, is the one that's going to maintain that lentiform or bulging appearance. That makes you think that is trapped, right? Otherwise it would layer out and flow freely. There are a few other utilities for this technique. For example, the subpulmonic effusion, which can be quite tricky when you're starting out to tell whether or not that's what's actually going on there. You can also utilize the Decubitus positioning on this patient, and again, if it's simple, it should flow and layer out just like that. You can see in the blue. Another frequent puzzle is if you've got a patient, these are usually patients that are very ill, ICU type patients, that have shadowing at the lung base, and you're thinking, is this consolidation? Is it consolidation plus a pleural fluid? I'm not sure. Again, you can take them, turn them on their side like that, take a picture in that Decubitus view, and if you see the effusion layer off to the side, you'll know that there was an effusion there at the lung base. All right, so let's take the time to compare a few more practical cases. So this is a good example of a loculated morphology, right? It's got like that bulging appearance, looks like it's putting some mass effect on the lung. You can imagine that fluid being trapped in that position. And we'll prove it by placing the patient in this Decubitus view. You'd put the affected side down, right? So we're worried about the patient's right side, so we're going to put him right side down, because that's the side we want to see flow. And sure enough, it's maintained that contour. Get a closer look here, just like that. So that's loculated. Now, does that mean it's an empyema? No, but you should start to think that that's a possibility when you see something like this. Compare and contrast that with another patient. Color this in for you. You can see how that's flowing more with like a meniscus type look. And this is larger volume, so it's not completely linear, but it doesn't have that outward bowing that we're seeing with our loculated case. All right, so we got a pretty good idea what these things look like now. I want to step back just for a second and talk about this. What does it mean? And a more important thing is this, like, am I missing something? Sort of like the feeling that maybe you left the stove on or the garage door up. Sometimes I feel like this. When I make a finding, I like to be able to explain things. I like to understand, okay, I got a pleural effusion there. I got a reason for him to have a pleural effusion. So let's recap the reasons you can have a pleural effusion. So we'll start out with the unilateral effusion. So one reason would be trauma. That could be blood, Another reason could be a pneumonia. Parapneumonic effusions are common. I feel like, I don't have the numbers in my head, but I feel like it's probably more common to have an effusion with a pneumonia than to not have one. If you've got a big enough effusion and it's at the lung base, you must always seem like you've got a little bit of pleural fluid down there. The other thing that you can have is a cancer. That could be a malignant effusion. Pulmonary embolus is always something good to think about. So if you've got a blood clot here and it gets squirted out into the lung, you end up getting a peripheral wedge-shaped opacity, which is going to be your pulmonary infarct. That's often seen with an associated pleural effusion. And that can be bilateral, because pulmonary embolus is often bilateral, so that can be unilateral or bilateral. And then there's subdiaphragmatic processes. So what do I mean by that? Ascites, pancreatitis, abdominal trauma. The diaphragm is not totally like water, like a watertight. It tends to be a little bit porous, so abdominal fluid can make its way up into the pleural cavity. um, ovarian pathologies, lots of different stuff, but anything that's making fluid in the belly can make fluid in the pleural cavity as well. It tends to be on that particular side, so a liver pathology tends to make a right-sided pleural effusion. And then bilateral pleural effusions, we mentioned this before, you can see that with CHF, fluid overload. And remember that that's more likely in the setting of cardiogenic pulmonary edema as opposed to non-cardiogenic pulmonary edema, the ARDS. One of the discriminators is that ARDS tends to not have the pleural effusions, whereas the cardiogenic pulmonary edemas tend to have them. So let's look at a practical case here. We notice, I sort of highlighted that one already for a little pleural effusion down there. And then we also notice we've got a peripheral opacity, sort of wedge-shaped maybe. So this could obviously be lots of stuff. We're going to run through our clinical algorithm like we talked about on the prior exam, and maybe this patient doesn't have a cough and doesn't have a fever, white count's normal, but they are acutely short of breath and they just got back from a long plane trip followed by a long car ride, and checked the D-dimer, that was positive. So this is actually a Hampton's hump, which is a chest x-ray appearance of a pulmonary infarct and a patient with a PE. Now don't make the mistake of thinking that you need to have something like this to have a PE. This is in textbooks. It's very uncommon in my experience to actually see the Hampton's hump. It's nice when you can see it, but you can have a pulmonary embolus on a chest x-ray. Chest x-ray appearance for pulmonary embolus is usually stone cold normal, maybe a little bit of pleural effusion, real non-specific pleural effusion that you're going to bias yourself with clinical history, and the correct first step is not a chest x-ray. It's a CT angiogram timed to the pulmonary artery, CTPA. But this is a case that you can't see that. So remember, I see a pleural effusion, I like to try to explain it. Common things, pneumonia, heart failure, etc. But don't forget about cancer, don't forget about pulmonary embolus. Alright, so that's the end of Chapter 1, which was the pleural effusion topic. Now I want to move on to pleural processes that are more solid, like pleural thickening and scarring, those kinds of things. So you'll see this a lot. They're, quote, ordinary type of pleural thickening. You see it at two main sites, the lung apex, which seems to be much more common, and then you can also have pleural thickening at the costophrenic angle, which can actually mimic a small effusion. We'll talk about the apical thickening first, since that's the most common. You see this in lots of different patient populations, people with emphysema, people with prior infections, the regular kind, and TB, inhalational-related lung disease, silicosis, that kind of stuff. All kinds of different things can cause a little bit of pleural thickening at the lung apices. It's usually mild, and it's so common that you'll often ignore it after you've looked at a bunch of these things. But you don't want to miss a cancer, because you can have cancer right there at the top of the lung. People will call that a superior sulcus tumor. It can also be called a Pancoast tumor if you've got Horner syndrome and some other clinical findings. So when do you need to worry? Take a close-up here. The general rule is asymmetry is bad. How much asymmetry? Most textbooks will tell you that if you've got 5 millimeters difference, or you've got it on one side that's 5 millimeters thick and the other side doesn't have any, 5 millimeters of asymmetry is going to trigger cross-sectional imaging. So I'll just say that without breaking out the ruler, if it looks asymmetric to you and it's bothering you, get a CT scan. It's worth the peace of mind to make sure you just rule out the cancer. All right, so let's take a look at a case here. Do a zoom up here at the apex. Whoop. All right, and we can see we've got really mild opacity there that's not black. Now compare that to a normal for you. Notice in the normal situation how we've got a really sharp appearance there at the apex. I can sort of look back and forth and see, yeah, there's just a little bit of irregularity there. This guy would be okay without, depending on your clinical suspicion, of course, but under normal circumstances, this is what sort of the routine looking apical pleural thickening looks like. It's pretty symmetric, it's pretty thin. Now, let's compare that to this situation here. We'll do another zoom up. What we have here is an obvious asymmetry, right? Big mass there. This guy would definitely be getting himself a CT. This case turned out to be a squamous cell malignancy. Alright, so we discussed the apical portions. Now let's talk about this thing down here where we've got some scarring here. This can occur from a whole bunch of different causes. Usually it's from a prior infection or some reason that blood got there, either a trauma or, well, I mean, trauma is going to be the only reason to get blood there, right? So prior trauma or prior infection are going to be number one and number two reasons to develop that scarring in this location. I mentioned before this can mimic a pleural effusion, tiny one. It will look exactly like it. The distinction is that it's going to be chronic over multiple priors. It's going to be unchanged, look exactly the same. And if you really needed to, we could do that Decubitus view that we discussed before, and this would stick. It wouldn't layer out because it's scar, not fluid. Have a look at a practical case. This is probably the most common look and the most common reason to see this, at least in my experience. So right there, close look, we notice that it's blunted. And now, I'm going to point out this right here. So these are sternotomy wires. This patient has had a prior CABG, prior cabbage. You can imagine that if you're in there, sawing bones up and sewing on the heart, that you could get a little bit of fluid, blood, in that pleural cavity. So that's like a trauma, a little bit of blood there. I feel like almost every case of post-cabbage that I've read, followed up, has had a little bit of pleural thickening or scarring at that. It's almost always on the left costophrenic angle. So you'll see this a lot. That's what it looks like, and that's the reason it's there. And like I said, you could prove it by seeing that it's persistent on multiple priors. If you really needed to, you could put them in the Decubitus view. Another case. Zoom up here. So this is a little different, right? Instead of being apical or being at the costophrenic angle there, this one's more lateral. Now, just like the pleural effusion, I like to explain things. Am I missing something here? So we'll get rid of that. We'll take a closer look, and with some aggressive squinting, and if you windowed it tightly, you'd be able to see that there's deformity there to two ribs. And we're going to have a dedicated talk on ribs, but this is a good look for some healed rib fracture. So this patient has had a trauma here directly to the pleura in that location, and it's healed with some scar that's kind of mass-like, and that's why we're seeing that lateral pleural thickening like that. This is probably the most common cause to see a little bit of lateral pleural thickening. I want to compare that to this situation here, which is quite different. Again, we do have pleural thickening in a lateral location, but now it's mass-like, it's lumpy and bumpy. If we zoomed in tight and looked closely, we can see that the ribs are normal looking. There aren't rib fractures that are healed there. This is bad. There's not a good explanation for this. There's some bad explanations for it. When you see something like this, you've got to get cross-sectional imaging to look at it. The moral of the story is that not every kind of pleural thickening is benign. You can get malignancies of the pleura. It's usually metastatic. There are rare primary pleural processes. Mesothelioma comes to mind, in somebody who's had a history of asbestos exposure. This is another situation here. Get a zoom in where we've got a mass. This one's not as large in the up and down or craniocaudal span, but it's still mass-like. This is you can't let that go. You gotta this has to be followed up with some cross-sectional imaging. So, quick review here. This guy, he could be okay if you can explain it. Real thin, especially if you've got associated stigmata of prior trauma. These two guys here are not okay. Mass-like, lumpy, bumpy stuff along the pleura needs to get cross-sectional imaging. Alright, so I mentioned before that mesothelioma is a possible cause for a mass-like pleural thickening, and that's commonly seen in the setting of asbestos exposure. The other thing that's seen in the setting of asbestos exposure are calcified pleural plaques. You see these things, focal areas of pleural thickening. The degree of calcification is variable. It can be lightly calcified, progress to densely calcified, almost as calcified as bone, like real white, real dense looking. They tend to involve the lower half or lower third of the lungs, and it's rare to see them in the costophrenic angles. I mentioned asbestos as the typical cause for this, but what if we've got a patient who's had no prior history of exposure? Can anything else cause this? Sure, lots of stuff can cause this. Prior hemorrhage can calcify, infections, prior empyema, including tuberculosis. If the patient has had talc, pleural desis, that can cause this. There's a lot of other causes, but the classic thing you think about is whether or not this patient has had exposure to asbestos. Alright, so let's take a look here. And I mentioned before that the degree of calcification is variable and it can change with time. So here we've got some increased density. This would be a lighter version. So take a look down here. Notice how dense that is, a real dense white line there. That's a dense calcification along the diaphragm pleura there. Here's a situation where it's much more severe. So he's got extensive pleural calcifications. Both of these patients had prior asbestos exposure. So this is, calcified pleural plaques in the patient and a patient with asbestos exposure does not mean malignancy. The actual development of mesothelioma is pretty rare. It's extremely rare in people who haven't been exposed. It's more common in people who have, but even in people who have been, the typical look is this calcified pleura. If it was something that looked mass-like or was bothersome to you, obviously you could get a CT to investigate further. I hope you enjoyed the lecture. If you'd like to see more lectures like this, you can go to teachmechest.com. Sign up for a free 7-day trial. This free trial gives you full access to the website, where you can find more than 30 didactic lectures similar to this one on all the topics you need to master interpretation of the chest X-ray. In addition, the free trial also gives you full access to more than 50 cases with the IRAD platform. Go to teachmechest.com now to join the radiology revolution.